Good afternoon. I'm Chiara Mimmi from Italy, and I'm going to talk about our phospholipid profiling of amniotic fluid from animal models. And in my talk, I will cover mainly 3 points. So I first will give you a short introduction about the medical problem in the field of prenatal surgery. Then I will say something about our phospholipid profiling by LCMS on this biofluid. And finally, we talk about our results. We are dealing with this congenital diaphragmatic hernia. It consists in the incomplete formation of the diaphragm in the fetus at the fetal life, and it allows the abdominal organs to enter the thoracic cavity and compress the lungs. And unfortunately, the prognosis is very bad for these CDH little patients, as it may cause death or anyway severe respiratory distress in the neonatal period. And in this project, I'm collaborating with 2 surgery units. So the first challenge actually was to make chemists and surgeons to talk each other. So that's what our first success, I think. And actually our colleagues are developing a method to make an operation during the fetal life. The idea is that if you manage to occlude the trachea, in this way you can force the lung growth, and actually the outcome is very positive. It is observed a remarkable survival rate increase upon tracheal occlusion treatment, depending also on the severity of the malformation. And actually it is now under debate in the medical community how and especially when to perform this operation. And so for this reason, our colleagues set up a research project with animal models, namely sheep. So what they are doing, so if we consider this, 147 days, more or less the last of the pregnancy length of a sheep. So what they do is first induce on the fetal lamb the malformation, and secondly they treat it with surgery, and finally they they perform cesarean section, and they evaluate the state of the lamb. And these 3 points correspond here. The second point corresponds around 26 weeks of human gestation, and the third points correspond to 38 weeks of human gestation. So here there's a scheme of the sample of amniotic fluid that we are working on. Maybe you know that amniotic fluid is currently used to evaluate the fetal maturity of the lungs. In fact, at the end of pregnancy, the lungs start to produce the surfactant complex. The major component of this complex is phosphatydilcholines, namely dipalmitoyl phosphatydilcholine. So what happens is that you can find traces of this surfactant also in amniotic fluid. And that's why in our study we focused on these biofluids. Okay, so here it's very important that you keep in mind our groups of fluids that we worked on. So healthy 2, healthy 3 means control fluids taken at these points. CDH2, CDH3 means the fluids after the malformation induction. And CDH3 plus TO means the final fluid after the CDH induction and surgery treatment. And okay, so Before going to the details of our experimental work, I'd like to point out how complex is, from the metabolomics point of view, working on amniotic fluid, since this fluid keeps on changing upon time. And here just wanted to give a flavor of that, so I reported this PCA graph concerning control fluids taken at different steps, different stages. So healthy 1, healthy 2, healthy 3. Okay, it's a very small sample, but it gives you an idea of how different can these fluids be. Okay, so going to the topic of my talk. As I said before, we focused on phospholipids because the ratio of phosphatydilcholines over sphingomyelins is a marker of fetal lung maturity. And since both these classes, when upon fragmentation, produce the same phosphocholine moiety, we exploited that and we performed precursor ion scanning to evaluate these classes. Must be kept in mind that in the current clinical practice, people just measure PC over SM by classical methods, like for example TLC. So what they actually get is only an idea of the bulk ratio without caring about the single species distribution. And on the other hand, we wanted to use LCMS also to have a more detailed idea of what happens at amniotic fluid samples. So in a typical AF sample, we find that we were able to identify 27 PC and 1 SM together with another SM as internal standard. So, and here, okay, sorry, here there was the typical total ion current product ion scan, and here the single extracted ion chromatograms for our target compounds. And here you can see a typical distribution of these compounds. This was an amniotic fluid healthy 2 sample. So our first observation is that the most relevant component is this one, POPC, palmitoyl olehyl PC. And another target molecule was DPPC. In fact, you may know that this is the major component of surfactant complex. So the idea is that, at least in a physiological condition, at the end of pregnancies, all mammalian fetus do swallow some amniotic fluid, and part of this fluid can reach the pulmonary cavity and then goes out again. So that's why amniotic fluid can recruit some traces of the surfactant, and so we can find it in the amniotic fluid. And okay, I know you cannot see the details of this chart, but if you try to look at it from the front to the back, you can have a flavor of how our different groups of samples looks like. So green is the evolution from healthy 2 to healthy 3, first and second series. Then CDH2 to CDH3, the evolution in the pathological situation, and then CDH2 to CDH3 plus TO. So the blue, the last series, refer to the situation after CDH induction and tracheal occlusion. And so maybe I move on to this zoom of this graph, because I'd like to point out that firstly, as you can see here from the major component of the PC class, you have a dramatic decrease of these components upon CDH malformation. And then, interestingly, you get a recovery of this molecule after the surgery treatment. So that was very nice. Another point is that, well, this was surprising. We were expecting, especially for this species, for DPPC, we were expecting to observe a strong increase from healthy 2 to healthy 3. So according to literature, this surfactant component increases a lot in amniotic fluid when you go to the end of pregnancy. But we don't observe it, and we have an explanation of that because actually we came across this paper where they pointed out that in humans things go a bit differently than in animals, in mammals. So while in humans surfactant production starts slowly but earlier than in the animals, and also in sheep. So probably since we are, allowing birth with cesarean section at kind of 38 weeks, if thinking to human pregnancy, so we probably stopped it too early to observe the exponential increase of surfactant traces, surfactant components. So that's our explanation of this strange behavior. But nevertheless, another interesting thing is that we don't see a recover. You remember the blue series means the final state after the surgery treatment, and we don't have a recover of the DPPC, but that's correct. I mean, that makes sense. In fact, as I said before, there is this physiological procedure of recruiting surfactant by amniotic fluid, but if you block the trachea, you stop this inhalation, exhalation process of amniotic fluid. You stop it temporarily. Sorry, I didn't that. It's just a temporary operation, reversible. And so, well, it makes sense that you don't find it at this step. So I'm going to the end of my presentation, and in summary, we performed this analysis of the phospholipids component of sheep amniotic fluid, and actually we discovered that the most important component is palmitoyl olehyl phosphatydilcholines, and we also we have an idea that also differential solubility of saturated and saturated phosphatydilcholines may play a role in this different recruitment by amniotic fluid. And no one seems to care about that a lot in literature, but we want to, investigate on that. And another point is, as I said before, that we found a lower concentration of DPPC than expected, but actually we have some hypotheses and some explanations. And the interesting thing is that we indeed observed a strong effect of the malformation, which provokes a decrease of PC, in general PCs, in the amniotic fluid, while on the other hand sphingomyelin seemed to remain at a constant basal level. And again, upon treatment, surgery treatment, we have a recovery of PC. So as you can understand, here we paved the way for the further investigation according to our colleagues, our surgeon colleague question, to answer their question about the timing and the best condition to perform these surgery operations. And so finally, I'm looking forward to extend the analysis also to intrapulmonary fluid, so the fluid which is trapped in the lungs after treatment with tracheal occlusion, because I want to verify, to validate our hypothesis on DPPC recruitment by amniotic fluid. And so finally, let me acknowledge people involved in this project, especially San Matteo Hospital in Pavia, in Italy, led by Professor Gloria Pelizzo. San Matteo Hospital also funded this research. And then in Vall d'Hebron Hospital in Barcelona, they grew animals and collected samples. And here there's I want to acknowledge Dr. Maurizio Ballico, my collaborator, who performed the majority of experimental work. And thank you for your attention. Thanks.